let's just review the Thomas test. So who wants to talk me through it?
What are you doing? You could just tell me to sit.
Who's jumping in?
So it's got to be one of you guys. One of you guys have to try to instruct him.
Well, you would have her edge herself to the edge of the table. She's already pretty close, so that's not bad. And then as she goes to lean back, you could help her with that. Go supine, yep. But she's only going to hold on to one of her knees. So I guess whichever leg that we're looking to test, she's not going to hold on to. So let's say we're testing the left. So you're going to hold on to your right.
You're right.
Yep, so that it doesn't go anywhere. And then you're going to try to straighten that leg out, your left leg out. Now, are you doing that on purpose or?
That's right.
Because we have a positive test here. Being that her femur or thigh is not making contact with the table, it's looking like we have a tight psoas or tight hip flexors. Yeah, and if her knee, you'd have to kind of edge her a little closer to the. It's hard to tell because it almost looks like her rectus femoris is tight too. Because her rectus femoris, her knee should be at closer to 90 degrees, and so it's looking like her rectus femoris is tight as well.
Right.
And then from this angle, it's hard to tell about the TFL, but if she were abducted, that would be a positive test for tight TFL.
All right. What else do you want to do after we do left side?
You'd want to check the unaffected side. The same.
All right.
Look at the same.
All right. Who wants to describe the ober? Dawn.
So you'll have the patient lie on their uninvolved side. So I guess for this purpose, so we can see that. So you're going to abduct the hip. So flex the hip first. And then you're going to abduct and extend. And
whoa.
and if the hip stays abducted, that means that there's tightness of the IT band.
Good.
Which is correct here.
All right, on your back.
Oh, you guys planned ahead for this.
That's the way it is.
What, my flexibility?
Yeah. All right, let's do 90-90. Ari, you want to describe 90-90?
Forgot that one. I was thinking of the Faber, but
All right, sorry, do favor.
Okay, so you're gonna lay down. You're gonna put their left leg, the ankle across the knee joint of the other, and you're gonna press down. If it's up, it's a positive test for the external rotator. I believe it's up. Is that testing the length of the adductors?
Anybody else want to help them out?
You're pressing too hard.
It's usually a generalized test that's used for testing limitations of like range of motion of flexion, abduction, and external rotation.
Yeah.
Right. So.
And if she has any pain in the hip, SI, or back, that would be an indicator of what specific location.
Right.
Yes, can be a provocative test too.
So what I'll show you now is the SI compression. So if you look at the anatomy of the sacrum and then the ilium and the joint there, the SI compression test, I would cross my hands, I would put it on the pelvis, right below the iliac crest, and I would actually push down. So I'm pushing down this way here. So I'm compressing the SI joint. So if it would be positive, she would have pain. So SI compression is I just push down like this on her iliac. And then if there's pain, it would be positive. What then you can do to confirm it, just like we did, say, the apprehension test, if they're positive, if I put my hand in and put the joint in location, it should feel more comfortable. I can sort of do a distraction then. Now I'm going to be on the opposite side of the iliac crest, and I'm going to sort of distract and pull up. So now I'm opening the sacrum, and that should be comfortable. So SI compression, I push down, and then the distraction, I'm pulling apart to make it feel comfortable. So that's the SI distraction test.
What exactly are you testing for again in that one?
The SI joint. So compression, I'm pushing down. So I know it's hard to see. It's just.
No, you could say.
So I'm pushing down, and I'm looking to compress the SI joint in the back.
For pain, mainly.
Yeah, I'm looking for pain. So if I compress it, it's painful, that's positive. The distraction is I'm now coming out, like pulling it apart, and so that should be negative, or it should make it feel better. And that's just confirming your compression test.
Kind of like the apprehension relocation for the shoulder.
Yeah, same type of concept, making it feel better. All right, so that's SI compression. All right, who wants to talk about 90-90 before we get into the new stuff?
I will.
Go ahead.
So what you're going to do is you're going to flex the hip at 90 degrees, preferably both of them. And in that position, you're going to extend one of the knees while maintaining that 90 degree. And if it's anything less than, anything greater than 20 degrees from full extension, then it would be positive for hamstring tightness.
Right. You don't have to do the other. You don't have to do both. So you can, in fact, you want to keep the other one down because I want to make sure my pelvis stays neutral. So you're right. 90 degrees of hip and knee flexion, extend up. If all I do is get to here, what does that indicate?
That someone needs to stretch.
Right. Good. All right. Everybody got that one.
What was the degrees again for positive?
Greater than 20.
Yeah, so right, so 20 degrees is about here. So 20 to 0, we'll start 0 as straight up. That's normal length. Anything below that would be positive for hamstring tightness. All right.
Professor D'Onofrio, before you do anything new, do you want to do the straight leg test?
Well, I'm going to do that. That's what I'm going to do right now.
Oh, okay.
Yeah.
I just have a question about the 90-90. So 0 would be it being all the way up. Okay. So if you can't get past 20, or if you get past 20, it's positive.
I go from 20 degrees of being, perpendicular to 0, then there's negative. There's no hamstring tightness.
Okay.
So the angle you would measure the angle from being perpendicular to the ceiling.
Okay.
20 degrees off from normally 180, but we'll call that 0 for this test.
Okay.
All right, and the straight leg raise test, we're raising up. I start to feel something here. So what's the straight leg raise test telling me?
Hamstring tightness.
Hamstring tightness, or what else?
Sciatic nerve involvement.
Oh, that hurts right there. What do you think it is?
Sciatic.
Nerve.
Sciatic. So sciatic is about 20 degrees, correct?
Yeah.
Okay. Can we just go over Kernig's sign again? I had a few questions about that.
Yeah, we'll do that right now, yes. But you got to do it with straight leg raise.
So with straight leg raise, I have up, if you get up above 60 degrees, the hamstring is involved. And if there's pain below 60 degrees, that's the sciatic nerve pain.
Yes, that's correct.
Okay. Okay.
And where would they feel that pain? Would it be anywhere along the sciatic nerve distribution or just in the hamstring?
Along the sciatic nerve distribution, it could be burning, it could be tingling, sharp stabbing pain, as opposed, you guys know what it's like to stretch your hamstring,
Right.
as a sort of like a muscle, like pulling.
Okay.
And so when you get to that point, one of the questions you're going to ask is going to be, describe the pain.
Mm-hmm.
Your muscle pain is always different than nerve type pain.
Mm-hmm. Okay.
All right.
Now, if they got up past, let's say they're at 70 degrees or 80 degrees or whatever, the pain from the sciatic nerve wouldn't necessarily go, or the symptoms from the sciatic nerve wouldn't necessarily go away once you get up there. It depends.
Probably not. But then you would still you would feel hamstring here and the nerve pain down there. But the key is once you get to this point and it's positive, there's really no reason to test. Beyond that. Once I get to here, if they're saying, "Oh yeah, it feels like it's burning," or I really feel it, I feel it in my calf. There's no reason for me to go higher than that.
And that's usually an HNP, right?
Usually, yeah. Or HMP, yeah. It could be a piriformis syndrome where the sciatic nerve is piercing the piriformis and that gets, clamped down on it. And then you'll do other tests to figure that out as well. All right, so the sign of the buttock, all you would do is, start with the straight leg raise test. But then if I flex the hip and I still have that pain on the same distribution, then that would be positive for some, what they call a space occupying lesion. Herniated disc, tumor, again, something that impacting or putting pressure on the sciatic nerve. So that is a sign of the buttocks.
And where would that compression be? Would that be near the piriformis or would that be
Again, it could be
towards the spine?
It could be anywhere along the length of the sciatic.
Okay.
Right. And then Kernig sign, Kev, you described Kernig sign. I always forget this.
Yeah, so Kernig sign is just something like if you think it's sciatic-like symptoms, what you can have them do, we can't see her head, but, if you suspect that, it might be like tight hamstrings and that might be causing some issue on her sciatic, what you do is you're doing the straight leg test. Professor Knopf, you just have her leg up at like 70 or something. She's starting to complain of burning or something, so what you tell her to do is tuck her chin. And that should put a little more tension on the sciatic nerve, and so she'll say, "Oh, it feels a little worse when I do that." And then you tell her to put her head down, and she's like, "Oh, it doesn't feel quite as bad." So that just gives you a bigger indication that there might be something like, tight hamstrings or something that's aggravating her sciatic nerve.
So Kernig sign no, sorry, go ahead. Did someone say something?
No, I get it.
So basically, I think there was confusion with these two signs and what they were exactly testing. So are they both testing for sciatic nerve involvement, or are they both, or is one testing for hamstring and one testing for sciatic nerve?
Are you talking about, so you're talking about like the straight leg test, or are you talking about what Kernig
So not
sign?
the straight leg test, because that kind of tells you where, if you're above 60 or below 60, what's kind of being involved. So with the sign of the buttock, you're basically seeing if there's a problem with sciatic, right?
So sign of the butt, yes, but sign of the buttock is that's a big red flag for what might be causing this, their sciatic issue, and it's usually the big red flag is they might have a tumor or something.
Okay.
Right, so a patient's coming to you, they're like, "I have shooting pain down my leg," and you're like, "Okay, hop up on the table. I'm going to do the straight leg test to see why they get the shooting pain." Right? And the patient does not complain of any pain in the first 30 degrees. So I'm like, okay, it's not an HMP because they're not complaining, in the first 30, 40 degrees. They go up into 60 degrees and they're like, you know what? This doesn't feel kind of good. I can do Kernig's test And I'm like, oh, this might be like maybe tight hamstrings or something. And then just as a little bit of a last minute check, I'll do sign of the buttock. So like I'll bend the knee. Okay? If all of their issues are being caused by tight hamstrings, if we bend the knee, are their hamstrings going to be tight?
No.
No. So should they have pain if I bend that knee?
No.
No. Right? So sign of the buttock is the last little bit to just be like, okay, I'm bending the knee. I want to see, okay, if the hamstrings are causing the issue, the pain should be gone now when I bend the knee. And they're like, no, I feel a deep pain in my butt. Right? And so then I know, okay, there's something there that's causing this pain. And that's what the positive sign of the buttock is.
So for Kernick sign, then basically you're still testing for the sciatic pain, just seeing like whether there's hamstring tightness that's causing that pain or sciatic.
Yeah, because sometimes when you're working on a patient, they're like, oh, I just feel a stretch when you're doing the hamstring, and you're like, wait, is it a stretch or is it radiating? Oh, I'm not really sure. So then I'm like, tuck your chin. And if they tuck their chin, they're like, oh, that hurts a lot when I do that. Now I know it's like...
Finish the video while I have the girls here, because when we're done with the discussion. Yeah. All right, so we're going to get involved with the knee test. First thing we're going to do is the anterior draw. And the anterior draw, did you guys do ACL yet in lecture?
No.
Oh, no.
Well, ACL, it starts at the anterior tibia, inserts back to the posterior femur. So it prevents anterior displacement of the tibia on the femur. Obviously, very common injury, basketball, football, usually occurred when the foot is planted and stationary and you get a rotation through the tibia, will put strain on the ACL. So one of the tests we can do is called the anterior draw. So remember, if we're looking to prevent anterior displacement of the tibia on the femur for the ACL, the anterior draw, 90 degrees, get the hamstrings to relax. Where do the hamstrings insert?
Well, on both sides.
Into the knee.
Tibial condyle. So the hamstring actually works with the ACL. So you'll see when we do rehab of an ACL injury, we want to really emphasize a lot of times the hamstring. So what I need to do is feel underneath, get the hamstrings to relax. And then grab the tibia, and I'm just looking to pull forward. So I'm pulling my force this way, looking to see the type of movement I have. And again, you're always looking to test both sides. Hamstrings relax, pull forward. And again, you're looking to see what kind of displacement you would have of the tibia on the femur. All right, so that's the anterior draw. The next one is Lockman. So Lockman is a more specific test for the ACL because it takes out the hamstring. The Lockman, 20 degrees. I like to put my leg underneath her thigh to stabilize. Hands the same placement, stabilize left hand up here with the right hand. I'm pulling forward. I'm looking to draw the tibia forward. So the Lockman is a lot more sensitive than the anterior draw because I don't have the hamstring involved as I do here compared to this position here. Okay? Next one, varus and valgus stress test, similar to the knee, to the elbow. So, right? Same thing, I keep the knee at 20 degrees, take the bony prominences out, right? If I keep it straight, the bones are going to keep it stable. At 20 degrees open pack position. For the valgus stress test, we're testing the medial collateral ligament. My hand is on the lateral side. My force is applied medially. So I'll stabilize the foot, hip slightly flexed, 20 degrees of knee flexion, and I'll just apply the stress towards the medial side. Varus is the exact opposite. Same thing with the elbow. Now my force is on the medial side, and then I'm applying the force laterally, looking to see if there's any gapping on the lateral collateral ligament. The positive test, you're going to see that medial side open up for the MCL if it's torn. All right, it's varus and valgus. Next, we're going to do McMurray's. McMurray's is going to test the meniscus. So with the McMurray's test, I start with the hip flexed. The knee is going to be at about 90 degrees. What I do is I put my hand on the lateral side to test the lateral meniscus. I internally rotate the tibia and I extend down. So I apply, good right there. I apply a slight valgus force, internally rotate, and extend the knee. That's going to test the lateral meniscus. If I externally rotate the tibia and do the same thing, that's going to test the medial meniscus. And so what I'm looking for is just pain. If there's pinching along the joint somewhere of the meniscus, I'm just looking for pain anywhere along the range of motion. All right? That's for meniscus. One more on your belly.
What you eating?
Go on your belly.
Ew.
Stop.
That's
On your belly. All right, next one we're going to do aptly compression. So aptly compression, patient's prone. I flex the knee to 90 degrees. So think about what the meniscus and the anatomy there. I'm going to apply a compressive force straight down. I put my force down, and then I'm going to internally and externally rotate the tibia. Same thing, if I go external rotation, I'm putting force or stress on the lateral meniscus. If I'm going internal rotation, I'm sorry, it's opposite. If I go internal rotation, the force is on the lateral meniscus. If I'm doing external rotation, the force is on the medial meniscus. And I'm just going to look for pain. So it's compression, internally rotate, externally rotate to see where the pain is, and that'll test your meniscus. Good. All right, let's go on your back. So let's go through them again. Anterior draw, 90 degrees. Palpate underneath the joint, the popliteal fossa. Hamstring relax. Pull forward. Look to see what kind of movement I have, testing the ACL. Lockman test. Support the leg. Same concept, grab behind the tibia, pull forward, see what kind of movement I have at the tibia. Valgus stress test for the medial collateral ligament. Hand on the lateral side, my force is applied medially. Varus is the opposite. Hand is on the medial side, force applied laterally, looking for the LCL. McMurray, knee is flexed, slight valgus force, internally rotate for lateral meniscus while I extend the knee. Externally rotate, extend the knee, looking for lateral meniscus. And then the aptly compression test is prone.
External rotation for medial meniscus or medial collateral ligament.
Yes. No. External rotation for McMurray is testing the meniscus. So external rotation for medial meniscus, internal rotation for lateral meniscus. For McMurray, for Apley, those two are testing the cartilage, the meniscus.
Both are for meniscus.
Correct. Valgus stress test, that's the MCL. Varus stress test would be the LCL.
Okay.
And
I have
for
a question
McMurray's,
about.
I'm sorry, go
Oh,
ahead.
go ahead. No, go ahead.
And for McMurray's, you're applying a valgus force either way?
Yes. Yeah.
Okay.
Yep, slight valgus force. It's not a big valgus force, it's a slight valgus force.
Okay.
For the ACL tests, both the anterior draw and the Lockman, when you say draw tibia forward to see what movement you have, like the displacement between the tibia and the femur, what exactly are you looking for?
Well, so you're comparing both sides. You're just looking to see the laxity. You should
Okay, the ligaments?
You should have some movement, but it's not a lot. If she tore her ACL, again, you'll see a lot of movement. We'll pull up some videos.
Okay.
Be a positive test. But you're always comparing other side. There's a machine out there that actually gives us a true value, but just for us to eye it, again, I'm just going to compare the other side. So if I have a lot of movement here on this side, and the other side is pretty stable, then you would know, okay, maybe there's a tear, or there's some, strain, or some laxity of that ACL.
So if you were to have a torn ACL, like you would also elicit pain when doing that, right?
You might not. If you have a complete tear, there might not be any pain.
Okay.
So I actually just haven't know. It's supposed to be 6 millimeters, so it is a big movement, but it's not that big at the same time.
Yeah. You're really
I know.
Like she tore her ACL. So you might have, what you'll have is instability. So somebody can tear their ACL, not necessarily have pain. Yeah, a lot of times you will have pain, but you'll have more instability. Hey, when I walk downstairs or I go downhill, I feel like my knee is going to give out.
Okay.
And I have these on video. You're done, thanks. So I have these on video. Kevin will upload them. This way you have yourself, and we'll just keep on, reviewing and going over them. Yeah.
So just one more time for the Apley's compression, when you externally rotate, that's testing the medial meniscus?
Yes.
Okay.
Yes, that's correct.
Same for McMurray's.
Same for McMurray's.
Yeah.
So we will try to find some videos to show you the laxity.
Yeah, I was looking. It's kind of tough. It's really hard to see, but yeah, I'm looking.
If we have a chance before lab is over today, can we possibly go over the course of the sciatic nerve? Because we went through it really quickly on Tuesday during lecture, and she said to know it before tomorrow. So if we have time, could we go over that?
All right, let's do it.
Yeah, Kev.
Okay, so where's the sciatic nerve start? I mean, what muscle, guys? There's a big muscle, sciatic nerve passes through it.
Piriformis.
Right, so we gotta, basically what I'm about to do is a version of what you could write on, a test or something. You could use it with words. I usually used to draw this. All right, so we got the piriformis, right? And the sciatic nerve passes through that. Sciatic nerve. And so the sciatic nerve is passing along the femur until it gets to the knee. What happens at the knee?
Splits.
It splits, right? So it splits into two different types of nerves. I mean, she did this super fast.
Is it the common fibular and the tibial one?
Tibial.
So the common fibular, or in other books you'll see peroneal. Peroneal. Okay. and then it's the tibial nerve. Okay, so we have a choice here. You can if you're talking about how it's running down, we can talk about how it goes down the peroneals or how it goes down the tibial nerve. But I'd say let's start by talking about, so where does the tibial nerve go through? I know she talked about it fast. I know we did a bunch of muscles today. Basically what I'm asking is it on the front of the tibia?
Back.
Back, right? So it's it's the posterior tibia, right? Posterior part of tibia. There it is. Okay. So the tibial nerve goes down, and it goes to a bony landmark on the bottom of by your ankle. There's only 2 prominent landmarks here. So
The calcaneus.
Suspension.
before calcaneus. Before that. Sorry. Okay. I guess we have a lot more than 2.
Medial malleolus.
The medial malleolus is the one I'm going for, right?
Okay.
So the tibial nerve goes down the back of the tibia until it gets to the medial malleoli, right? Or medial malleolus. Okay? It bursts down the medial malleolus. It becomes too... I don't have enough space. I'm kind of going to go both ways. So, what are the 2 nerves? Did you talk about it? Do you have it on a PowerPoint?
We only introduced the beginning stuff. We didn't go deep into all of this. Yeah.
The medial and lateral plantar nerves.
Correct. So basically what happens is the tibial nerve is going to go around the medial malleolus, and it splits up into the medial plantar nerve and the lateral plantar nerve. So it's kind of you remember how in your hand you have the median nerve on one side, the ulnar side? That's what these nerves are. They're kind of they're those versions of the median ulnar nerve, but in your foot. Okay, so now talked about what all the nerves start to get. What happens with the common peroneal nerve or the common fibular nerve?
Kev, you just cut out real bad.
Oh, did I?
Yeah, just so you know.
I'm sorry.
You've been
I don't know. Well, I said a lot of stuff, and it's never going to come. Sorry. Well, I mean, what I was basically just saying is we've talked about the tibial nerve, right, and what it splits up into.
Yeah.
So what can you say about the peroneal nerve? What is it? What happens to that?
Before we go to the common peroneal, as far as sensory distribution, what's the difference between the medial and lateral plantar nerves?
Is going to be just on the medial side of the foot.
Okay. So
side of the foot.
So lateral.
And it's on the bottom. It's on the bottom part of your foot.
Okay.
Right. So we're talking about the plantar surface. So it's if you step on something like a rock or something, if you feel it on the medial side, it's more than likely you're picking it up from the medial plantar, right? And then if you step on something and it's more lateral, it's your lateral plantar nerve.
Okay. And you said the lateral is underneath the foot?
They're both underneath the foot. That's what the plantar means. It's talking about the bottom part of the foot.
Okay.
Okay. So going back with the common peroneal nerve or the common fibular nerve, what is that split into? I mean, I guess you guys haven't covered it, right? So
it was very quickly.
Yeah. So it splits into the superficial.
That's right.
Superficial and deep peroneal nerves. Superficial and deep peroneal nerves. Or again, you could say fibular. In some books, they're going to call it fibular. In other books, they call it peroneal. I think the state board now does a lot more with fibular. Lindsay, do you know anything about this? Is it more fibular? Is it more peroneal?
It'll say both.
They'll say both?
It'll say like, peroneal, parentheses, fibular, whether or not, depending on how each person had learned it. So it'll say both.
Okay. The big thing to remember about the common peroneals, it does this split at the head of the fib. Okay. The superficial peroneal nerves go to, we haven't talked about these muscles yet, but this goes to like the lateral part of your foot. Lateral, I'm just going to say lateral part of the foot. And then the deep peroneals, they go to your dorsiflexors.
So like tib anterior?
Yeah.
Okay.
Right. So we were kind of like imagining it like it's the hand, like your deep peroneal. Think of it kind of like your radial nerve. It does like the dorsiflexion of the foot, or extension of the foot. Right. So when we're talking about the piriformis, the run of the sciatic nerve, this is the kind of stuff she wants you to know. Do you need to have this all perfect? No, but by your final, you definitely want it to be perfect. By your lecture exam, you want it to be perfect. Right? So you could draw it like something like this, or you could say it with words. You could say like sciatic nerve passes under the piriformis. When it gets to the knee, it splits off into the tibial and common peroneal. And then you could say common peroneal splits at the head of the fibula to whatever. Like you can literally write it in a paragraph, or you can draw it.
Is there a way you could like screenshot this and like email it to us?
I could, but I totally could, but you could also just screenshot it right now. We live in the future. But I mean, I sort of hate the way this looks, but yeah, I'll screenshot it. Sure. All right, I'll send it to you guys.
So, Anita, you wrote in the chat, know where the sciatic nerve originates. So it doesn't originate from the piriformis. Where does it originate? Do we know?
I've heard L4 to S3.
Yeah, that's when we're talking about like sacral plexus type stuff. But yes, I always forget that, guys. I apologize. I should have put that there.
No, I can look it up. But L4, S3.
Yeah, so throw that above where I wrote piriformis on the web.
Yeah, because she will ask that.
She will definitely. I realized she definitely asked that, and that was the thing that I would always forget to put, and she would take points off. So.
So L4, S3 is what we're looking for?
Yeah, that's where we're going to start from.
Okay.
Right.
So instead of the piriformis, or leave piriformis there too?
Yeah, we're going to leave piriformis there, but we're going to say like L4, S3 through piriformis, and then becomes sciatic nerve, and then does all this stuff.
Nice.
So with the like the lumbosacral plexus, the drawing that she gave us, or the diagram she gave us in the PowerPoint, do you recommend like knowing how to draw that too, or like not as crazy as the brachial plexus?
No. You don't need to you just need to be aware of it. You don't need to know it like you need to know brachial plexus. You need to know like this thing. This thing you need to know.
Okay.
With this these she will ask you.
Yeah.
I recommend redrawing what Kevin did. No offense, neater and cleaner for you to understand.
Oh, for sure. Yeah. And that drawing that I did is kind of like the sacral plexus. Like it's not the sacral plexus, but it's what you need to know. So make sure you know like what muscles come off of these nerves and stuff like that. Like she will ask those types of things.
Okay, so what muscles come off the tibial nerve, the common fibular nerve, and then like the deep peroneal, superficial,
correct,
medial, lateral plantar. Okay.
Correct. She might give you a question where it's something like you have a fracture at the head of the fibula, like what actions might be affected. So you gotta, you have to think, oh, if there's a fracture at the head of the fibula, my superficial and deep peroneals nerves are not going to be working. And then you got to be like, oh, what muscles are those? What actions can't they do? Like, that's the kind of thing she might ask. Or, she says a fracture in the posterior tibia, like, tibial nerve is affected. What actions can't you do? That kind of stuff.
And then I guess it goes without saying, sciatic nerve is the biceps femoris, semimembranosus, semitendinosus.
Yeah, those are all your hamstrings.
Yeah, all the hamstrings, okay.
And one more. There's one other muscle that's part sciatic. And
Magnus.
Yes, adductor magnus. So she could theoretically, on a quiz, hint, maybe be like, name all the muscles innervated by sciatic, and we expect adductor magnus to be there.
As well as obturator.
Yes, yeah. I mean, adductor magnus is also obturator.
Yeah. Okay.
So the rest of that diagram of the lumbosacral plexus that she gave us isn't super important?
No.
Okay.
And
That's
also, like with the sciatic nerve, so if she were to ask you like what muscles are innervated, you would just have to name the 4 like muscles that are innervated by the sciatic, not all the branches, unless she asks like what muscles are innervated by the lateral plantar nerve.
Yeah,
okay.
Yeah.
Thank you for going over that.
She's like gold here.
Oscar, do you want to get back to what we were talking about early?
Yeah, the sign of the buttock type thing.
Sure.
Yeah, I mean, so basically, like, I guess part of what might help, you guys are learning the tests, and you have to keep straight all of these things. Like, what is the test for? How do you do it? What is your positioning? Like, so I know, we know it's a lot of stuff, right? But, like, like the way we do the straight leg test is, for example, like, I've had patients come in and they complain of a shooting pain down their leg. And you ask them questions like, when do they feel it? Or, like when does it feel the worst? And they might say they might give me some information and it might give me some more hints. But the first thing I'm going to do when they say shooting pain down the leg, I'm going to say, okay, let me do a straight leg test. Let me figure out if it's an HMP or is it more of like a hamstring tightness thing. Okay, so I do the straight leg test. How would I know if it's an HMP? What would be a strong indication that they have an HMP and that's what's causing their symptoms?
Well, as you did the straight leg test, they would feel it pretty quickly in the first, 40 degrees, and it would be more like tingling and numbness than anything else.
Yes, right, exactly. So, like, I can think of a patient I had who, I put him on the table, and I just brought his leg up maybe 10 degrees, and he was like, this hurts a lot, right? And so I knew right away, like, he's got something going on, like, that's an HMP.
Where was that pain?
He was having radiating pain all along the back of the thigh.
Okay.
So, I mean, again, that shouldn't have been hamstrings. He shouldn't have been having hamstring pain in the first 10 degrees of hip flexion. So I knew it wasn't a hamstring tightness issue. I knew if he's complaining about a pain in the back of his thigh just from me lifting his leg 10 degrees, he probably has an HMP. Okay, and he did. It turned out that he did have an HMP.
But one of the things, again, you guys, early in your career where you're looking, maybe your mindset is like through one test, it's going to tell us exactly what's going on. A big part of what we do is being investigators. So you can have an idea of, what it's going to be like, in your initial, your conversation, assessment with the patient. And so say, somebody when you're asking questions, for instance, like, what kind of work do you do? Like, well, I work in a warehouse at UPS, at FedEx, and I was lifting packages all day, bending down. And so, you have a pretty good idea, what the person's history, medical history, social history, what you would want to then look towards. So if I have somebody that's lifting packages all day, maybe I ask them to do it, and then I see them bend and twist. And what is that indicative of?
RHNP.
Yeah, that's indicative of AHP. As opposed to, say, somebody who would be like, well, you know what, I was out for a run, and I made a quick turn, and I just got like this searing pain down the back of my leg. So your history is different for both those people.
Right.
The types of what's going to be important is, describe the pain for me. Nerve pain is going to be searing, burning, tingling, radiating.
Yeah.
Muscle, hamstring type pain could be dull. It could be achy. It could be like even, sharp. However, do you think if the muscle is involved, if the person is at rest, are they going to have any pain?
Not nearly as much. Very little.
Yeah, probably not. You're going to have pain when you activate those muscle fibers. And so when you're looking at these tests, don't just think like this one test is going to really tell me exactly what's going on. A lot of it is going to be, the other questioning that you do, the mechanism of injury, their history. But again, these tests will just a lot of times confirm, but these tests are also good to do as a baseline, because then we can do it again a few weeks later to see if in fact what we're doing is helping. If I'm treating somebody with the low back pain or sciatica, and I do a straight leg raise and I only get to 20 degrees, but then 2 weeks later I get 40 degrees, I can document that and just to show to the insurance company that we're making progress through what we do.
Yeah.
So yeah, know these tests, but just don't think that, you have to be so specific or these are going to really tell you everything that you need to know.
Right. They're more just like you do them to clue in on what you think might be the issue, right? And a lot of these special tests too, it's usually not just one. Like Professor D'Onofrio was saying, is you have to ask them their history, and you kind of have an idea of what might be the issue. You might ask them to demonstrate what they do throughout the day. You ask, you take a lot of different pieces of information together to kind of come up with an idea. But so going back to this thing with the straight leg test, okay, so let's say the person didn't have pain in the first 40 degrees, and they complain of like a kind of pulling, achy kind of pain when I'm doing the straight leg test and it's at like 70 degrees. What do we think?
Probably hamstring tightness or related to the hamstring.
Right, something maybe with the hamstring going on. How do I know if it's like hamstring tightness that's like pulling on the sciatic nerve? What sign could I do to exacerbate it a little more?
Kernick sign.
Right, I could do Kernick sign.
Okay.
Right.
So, have you seen situations where they don't have pain in that first 20 degrees or so of hip flexion, but you get it with the Kernick sign?
Yeah. Like I've seen it before where, I'm working with the patient and I'm pretty sure they have a hamstring issue that's causing their sciatica, but when I take them up, they're like, it doesn't really hurt that much. And even though it feels like they're super tight, I'm like, this should probably be aching a lot. He's like, nah, it's a little uncomfortable. So then I tell them to tuck their chin, and they're like, oh yeah, that really bothers me.
So that would be more of, so the Kernick sign, you're looking not so much for hamstring tightness, but you're looking, I guess maybe it is, but it's more of that nerve entrapment.
Yes, you're looking to see that you're looking at something is causing a lot of excess tension on the sciatic nerve.
Okay.
Right. Kernick sign, you're not concerned about hamstring at all for that.
Yeah.
Okay.
You've done other tests.
Is that why?
You've done other tests to rule out hamstring.
Mm-hmm. Okay.
Is that why, when you're in the clinical setting, sometimes, when you have a patient doing, nerve glides, you have them tuck their chin to kind of find where that pain is to see if it's, if it's related to sciatic, or is that for, a different nerve?
It depends on how they're positioned, but you can do nerve glides with patients, and so you put them, the way nerve glides work is you're kind of making that nerve go into, a little bit more tension and then a little less tension. And that very act of your positioning will put certain nerves on that tension.
And would kerning sign be limited to just pain in the hamstring, or it could be anywhere along that sciatic distribution?
It could be anywhere along the sciatic.
Okay.
Right, but you're by doing that kerning sign, you are putting a little more tension on it. So if they're having a sciatic-like issue, kerning sign will exacerbate it, for sure.
So by tucking the chin, it's more going to be like it might not just, you won't really feel the sciatic pain until you have them tuck that chin.
Perhaps, yeah.
All right, this is what you guys are going to do.
You'll understand. Okay.
You guys were all sitting, anybody lying down, standing? All right, everybody, your seated position. You're going to slouch. Right? Keep the head up now, and then you're going to extend one leg. And then really tuck your chin, and really, tuck your chin down. Anybody feel anything under the leg?
A little bit.
Oh, it goes up a little bit.
Some pulling.
Tension.
Yeah.
I felt it more like around the piriformis mid-hip. But
All right, now do it again, same thing, but now I want you to dorsiflex and plantar flex your foot as you do it. But you
Our
gotta
leg extended
Case, make sure you slouch. What's that?
with our knee extended, right?
Yeah, so slouch, tuck the head, extend.
Oh man,
That doesn't feel good.
That's what you would feel. So if somebody has a positive kernick sign, that's what they're going to feel.
Yeah.
And now I want you to just, stretch your hamstring. You feel the difference between stretching the hamstring and doing what we just did as considered the slump test.
nice.
Right. And so notice that. I know, Brian's not able to speak here. But he said he felt it in the lower back. But yeah, that's what you're going to feel. So anywhere along, so think about your nervous system. Think about your tracts. Not necessarily your spinal tracts we'll get into. But around the brain, we have that dura mater, that covering. So that covers the brain, but that also goes and surrounds the entire spinal cord, and it also surrounds all our peripheral nerves. So at the different levels of the spinal cord that exit, that make up the sciatic nerve, that dura mater covers it. And so nerve doesn't stretch, it glides. So when you're slouching down, and then flexing your head, extending your knee, and then dorsiflexing, you're putting that sheath on maximal tension. That's the stretch. Not only stretch. That's the tension you feel. That's nerve. That's the kernick sign. That's the straight leg raise sign. That's what you're gonna feel.
Right.
When we do the 90-90 test, why don't we feel it on the 90-90 test?
Because it's on slack.
It's on slack, yeah.
So it's almost like a lesion in the meninges that we're kind of looking for.
It could be anything. It could be anything going on that. Like there could be, some kind of tissue adherence. Like there's something just kind of pressing on the nerve. You don't necessarily know anything. You just know that there's something going on with the nerve. That's it. You can't specify what.
Right. It could be a herniated disc. It could be a tumor. It could be a stenosis, a central stenosis where the canal, the canal between the vertebrae gets smaller, or it could come out where the nerve root exits, whether it's arthritis, old age, whatever it could be. Again, a true piriformis syndrome is when the sciatic nerve actually pierces through the piriformis, and then if that gets tight, it presses on it. I had a patient who had a hamstring tear, a proximal hamstring tear. And when you tear a muscle, you get bleeding. As he healed, the scarring of the blood adhered to the sciatic nerve. So he had that radiating pain down the leg. They were doing MRIs for his back. There was nothing in the back. We did this slump test, and he was excruciating pain. He got better through stretching, and then that's nerve glide. So it can really occur anywhere. Another patient I had who I was treating him for plantar fasciitis because they had pain in the bottom of the foot. After like 4 weeks of not getting better, they decided to do an MRI of the back. She is positive for herniated disc of the back. So it really could be along any route of that sciatic nerve.
Yeah.
Or if it's up higher, could be the femoral nerve. Could be anywhere. Make sense, guys?
Yeah. It's like Anita's been telling us. It's like your patients will keep you up at night, and you know, you go home, you got to think about what's going on.
You do, yeah, absolutely. And it goes back to that question that we did before we left of upper extremity. Your friend comes to you, or their patient comes to you complaining of pain in the 3 fingers. Well, it could be carpal tunnel, it could be pronator teres syndrome, it could be entrapment of the median nerve anywhere along the way. It could also come from the neck. And that's the investigative work we have to do, and that's how we use these different special tests to try to sort of maybe rule out something, but then, try to, dwindle it down to get a better idea of, what I need to work on.
Yeah, these are the tools to add to your detective toolbox.
Yeah.
That's what we're doing.
And then it's range of motion and seeing how the joint is. It's going to be manual muscle tests, which we get into. It's going to be goniometry, which we get into next year. So all that stuff is just going to help you be that investigator. So on Wednesday, I know you guys were talking about, how do you apply this? I wrote up a few scenarios. I'll write up more that will be able to incorporate what we're talking about here and what we can do, what special tests. There will be some exercises, that you guys will come up with, which you haven't really done yet, but we'll keep it basic. But on Wednesday, we'll do that. You'll review the special tests again. We'll do the muscles, the new muscles that you have. We'll quiz you, but then we'll get into more of a clinical approach to exactly what we're doing right here.
Do we want to have them try and do videos of the special tests for Wednesday, or should we try and have them do it for next week?
Whenever they can. If they can do it. So basically what we were talking about, like I can do the special tests. I can put the videos up and you guys, send it to you guys. That's great. But I think what works best is if you guys do it yourself. So over the next couple days, if not the next week, if you can get somebody, a family member, friend, somebody you feel comfortable with that's not going to give you COVID, and just do the special tests, try to video it, and then we'll bring them up and we'll critique it, because that's really the best way that you guys are going to learn.
Yeah.
Right? If you don't have anybody, we completely understand. You'll still learn from what everybody's doing, but for those that can, it would be nice to be able to, for you guys to video.
Yeah.
You have the papers, Thomas, Ober, Faber, then all the stuff at the knee that we had done today.
Do you want us to take a video of us doing it on a family member and then email it to you guys?
Yeah, I'll set up a folder on a Google Drive, and everybody just put your name and put the video inside your own folder. Or I'll have folders for each of your names, so you can just upload the video into your own folder.
Okay.
Yeah.
And then the ones that I did will be there too.
Yeah, the ones that he has will be there.
All right.
Yep.
I would just like to say that you guys are doing fantastic, all things considered, with being that it's virtual. I think this is pretty wonderful, the way we go over everything, and I feel like it's extremely productive. So
yeah.
Thank you for your good work.
You guys are doing great. You guys are really, we're making the best of it, and you're asking good questions, and we'll all, just one day at a time here. You guys are all doing your part.
You're reading some stuff over the weekend. There is light at the end of the tunnel. It might not be as soon as everybody hopes. There's one top doctor out of University of Wisconsin. They're getting hammered there. Basically said if people can just make the sacrifice for 3 more months, we'll get there. And so not to get on the soapbox about what we're doing. But just for you guys, next semester, if and when we get back to the school, we'll revisit this. We'll revisit this all of next year, because a lot of what we do next year is repetitive. However, we add more of the clinical stuff to it. What exercises, how you would treat acute versus chronic, in a hospital compared to an outpatient. But we do the special tests. Everything that we normally would do now, we'll review again next year. So, do the best you can to learn it. But I guarantee we'll do it again, because the stuff that you're learning now, you're not going to memorize and know in a year from now. But again, we'll make sure we go over everything.
Yeah, so this is like giving us the foundation, and then, yeah.
I just have a quick question about the practical next week. So, I know we've asked this question a couple of times, but will the pictures on the practicals be of models, or will they be of things we've been doing in class, looking up pictures of them? Just because I feel like then we can cater our studying a little bit more towards searching Google images of models instead of pictures.
So Lindsay and I are the ones who are going to be setting that up. It's going to be right now. It's going to be models.
Okay.
Okay. Where she has a leg model, we're going to be taking pictures. So it's going to be from the leg model. We're going to try and take very clear pictures for as many as we can. We may need to put some pictures from Google for certain muscles, but if it is, we're going to try and make it very obvious what we're looking at as best we can. Right? It's not going to be some kind of weird, tiny little muscle that you can't tell. It's going to be something that should be very clear.
And just a quick thing about the last practical, I don't want to be offensive or anything, but a lot of the pictures, the orientation was so strange that we were all kind of like this. So if it's possible to maybe put it upright. I don't know if you guys.
I know that. I am fully aware. Believe me when I say that. You would have hated the other pictures that were the choice. Yeah. So I tried to put the best one that I could. But yeah, we'll try and have some clear landmarks that you can see to at least orient yourself. Yeah.
We have a little better idea of how to go about it too this time.
Yeah, I mean, it was literally you guys went online and it was oh, we're doing a practical in a day. So
of course, we totally understand that too. And it was better than what we had expected, but just kind of for this time around, I think we've all learned how to.
So what you're trying to say is you don't want me to put any upside down pictures. Okay.
Yeah,
for you, Ashka, I will purposely not. Maybe I'll throw in one upside down.
We should. It's fun.
Yeah.
Okay, thank you.
All right, so you guys have any other questions?
I think so.
Okay, so if any of you can, try and put up a video of one of the special tests that you can. So Lindsay and I will set up a Google Drive folder and send it out to everyone so you guys will know where to upload the video. And part of what we'll be doing moving forward during lab is we'll review those videos. We'll be okay, what do you guys think? Was the setup okay? Were her conclusions okay? That kind of thing. And what else? I guess we're going to put up the video. Yeah, really try to do it if you can within the next couple of days. It doesn't need to be in the next 2 days, but if you can within a week, I think it would be beneficial.